Well, today we are going to talk about urinary tract infection in children. The participants we are Pacheco Esteban, Perez Matias, and Sainz Thais. Next. So the symptoms of urinary tract infection in young children are not specific, and urine sampling is tightened and safe, and repeat diagnostic of urinary tract infection can be achieved with a new biomarkers and culture of clean check urinary, in receiving catheterization or suprapubic aspiration for severely ill infants. Most guidelines recommend ultrasound assessment and use of risk factor to drive factor management of children at risk of kidney deterioration. The increased knowledge of the innate immune system will add a new prediction and treatment strategy to the management of urinary tract infection in children. Next. So the urinary tract infection is common in children and affect the 1.7% of boys and 8.4% of girls before the age of 7 years. It's more prevalent in the boys in the first 4 to 6 months of life, but after that year are more often affected. The clinic manifestation vary from life-threatening septic infection to asymptomatic bacteria. The urinary tract infection can be divided in three categories. The first is acute pyelonephritis, affection the kidney, cystitis, restriction to the lower urinary tract, asymptomatic bacteria. The kidney damage and abnormality of the kidneys and urinary tract are usually identified during the first few years of life after the first febrile urinary tract infection, or as is happening in Christ by prenatal ultrasonic examination. The diagnostic in the children, in all children, the presenting symptom is clean flag pain with fever, urgency, and frequent violence, intoxinates, and dysuria. In young infants, the symptoms are often vague with fever, inadequate feeding, or failure to the tract. In such case, urinary lysis is warranted and the urine sepsis should be sent for culture in select case. The alternative is an algorithm include factor the mix and urinary tract infection. More like can be used the with client when to expect a urinary tract infection, making diagnostic products and urine sample more manageable. As most children with K abnormal is usually present with a urinary tract infection, the diagnostic were up and the grade for a urinary tract infection must be tracked and correct. The urinary spilling is a representative urine spill is crucial for diagnostic achieved with a suspect to urinary tract infection. In not toilet tried children, not invasive time has a high prevalence of contamination in urinary cultures. Of the invasive states used, suprapubic aspiration has the lowest contamination rate followed by catheterization, and some authors have found catheterization to be less invasive and not as painful comparative with a suprapubic aspiration, whereas in a recent study the opposite was not. In the toilet tried children with biliary bladers control midstream, but iron is usually softened. And the urine biomarkers, the leukoturia identifies with the leukoturia stress test or by microscope is a strong identification of bacteria. The sensitive of 83% and specific of the 78%. The leukoturia may be a vaccine specialty in urinary tract infection with low bacterial constitutions caused by no Escherichia pathogens. In the facts, the nitrite test is the most negative because the offshore bladder urinate incubation times. In other urinary biomarkers for the diagnostic of the urinary tract infection in children have been explored. Something studies have found in neutrophil gelatin association with gallins and interleukin-8 to have sensitive and specific in differentiating in urinary tract infection for the other fevers like in children. And the urinary cause, the growth of a single strain of the uropathogen bacterium is indicative of the urinary tract infection. There were multiple strains in most cases indicated contamination of the urine sample. The significant growth in uri was defined more than 100 colony forming units per milliliter and creates a criterion original to exclude a contaminated samples. Many recognize that a contamination sample from suprapubic aspiration and so normally be sterile and the bacteria should less frequently contaminate categories or samples.
Treatment. When UT is suspected, empirical antibiotic treatment should be started as soon as possible. Oral antibiotic treatment is as effective as intravenous administration. The initial treatment can safely be switched to oral administration, but however, for children below 2 months of age, the scientific data are sparse and pending further studies. Initial intravenous treatment is usually recommended. The choice of the empirical treatment relies on the antibiotic resistance profiles in the community and depends on the availability of drugs suitable for children. The prevalence of bacteria with multi-drug resistance and extended spectrum beta-lactamase production poses an increasing problem. Such infections have more complicated clinical course with potential delay in starting appropriate antibiotic treatment, increase the length of the inpatient stay, and other complications. And for many years, cotrimoxazole with high bioavailability and good penetrance to parenchymal tissue was the treatment of choice in many countries. Owing to the increasing resistance, it can only be recommended after urine culture has shown the bacteria to be sensitive to this treatment. Third generation of cephalosporins are usually effective, and other alternatives include amoxicillin with clavulanate and quinolones with their widespread use in the adult population are discouraged in children. They usually be shaped to selected cases with multi-drug resistance. Uh, Finally, there is a consensus in most of the guidelines that mean that the treating febrile UTIs for 10 days with a span from 7 days to up to 40 days when treating the more severely ill child with a suspected or manifested septicemia. For cystitis in children above 2 to 3 years, where kinder involvement can be ruled out, most of the guidelines recommend 5 days of antibiotics, with some studies supporting an ever shorter 3-day course. In relation to asymptomatic bacteriuria or ABU, it can be found in all age groups. In infants, the duration of ABU is usually limited to 1 to 3 months. In other children, ABU is typically seen in girls with bladder dysfunction causing infrequent or incomplete bladder emptying. ABU is also frequently found in children with neurogenic bladder dysfunction causing infrequent or incomplete emptying, or those requiring indwelling foreign materials such as catheters or vesicostomy tubes. ABU may be considered as a kind of partnership between the bacteria and the host, protecting against symptomatic UTI in susceptible individuals. In relation to the antibiotic prophylaxis, prophylactic treatment with low-dose antibiotics to prevent recurrent UT has been common practice for children with VUR. The use of prophylactic antibiotics has declined substantially after proof of only moderate or no effect on the rate of recurring UTI in several studies. The increasing of bacterial resistance and the low adherence to medication have also contributed to the decreasing use of prophylaxis. However, in selected patients carefully followed, prophylaxis can protect them from recurrent UT. In relation to the evaluation after urinary tract infection, the evaluation after UT aims to detect underlying congenital abnormalities of kidneys and urinary tract, kidney damage, and bladder dysfunction, recurrent UTI, and future deterioration of the kidney function. The congenital kidney anomalies in children are often diagnosed during evaluation for UT, especially in countries where prenatal ultrasound in the last trimester is not regularly performed. Congenital damage is more common in boys, whereas in girls, kidney damage is usually acquired from recurrent UTI. The extent of kidney damage is closely associated with UTI recurrence to the high grades of dilated BUR.
Okay, now I'm going to talk about ultrasound. Ultrasound is the recommended test after first-time UTI in infants and a febrile UTI in older children. It's a useful tool to identify obstructions, dilatations, and major abnormalities in the kidney, such as size and location. However, it cannot reliably detect kidney damage or vesico-ureteral reflux. The quality and interpretation of the results can vary depending on whether the ultrasound is performed in a practitioner's office or by a radiologist. It's important to be aware of these limitations when interpreting the results. To increase the quality and consistency of the examination, a helpful checklist is available for the kidney bladder ultrasound. Further imaging now. Two main strategies for additional renal imaging after childhood UTI. It's bottom-up or top-down. Bottom-up strategy aims to identify children with vesico-ureteral reflux and manage them with prophylaxis and or surgical intervention if necessary. Avoiding cystoretography is the gold standard for BUR grading, but has drawbacks like catheterization and radiation. On the other side, contrast enhanced ultrasound and radionuclide techniques have been proposed but offer less detail in grading BUR. Top-down strategy focuses on the kidneys and preservation of kidney function, relying on the fact that BUR of any significance is associated with kidney involvement. Nuclear scintigraphy can identify kidney involvement in the acute phase of infection but must be done shortly after treatment initiation. Restricting BCUG assessment to children with manifest kidney involvement or dilatation on ultrasound can reduce the number of BCUG substantially. On the guidelines of urinary tract infection, we can say that they have been revised to reduce unnecessary investigation and identify high-risk patients with kidney or urinary tract anomalies. Risk factors for these patients include fever, infections with non-E. coli bacteria of abnormalities on ultrasound examination, particularly urinary tract dilatation. Some guidelines may also consider inflammatory markers such as CRP and PCT and white blood cell count, as well as recurrent UTI, severity of clinical presentation, and young age. Different parts of the world have been their own guidelines, but the main features are summarized for easy reference. The risk factors for urinary tract infection and kidney damage. It's important to identify children at risk of recurrent UTI and kidney damage. High-grade VUR, urinary tract obstruction, and bladder are risk factors for kidney scarring. Increased inflammatory markers like CPR and PCT indicate kidney involvement and potential kidney damage. Treatment delayed increases the risk for acute kidney damage and probably permanent scarring. Non-E. coli UTI is also a risk factor for kidney damage, especially in children with urinary tract obstruction or insufficient bladder emptying. Also, the innate immune system and polymorphisms within it play a role in defense against UTI. Mutations in IL-8 receptor and INF3 receptor increase risk of symptomatic UTI and kidney scarring. Some urine proteins and peptides, such as cathepsin, have antibacterial effect on their promotion is dependent on serum vitamin D level. Low vitamin D levels are associated with an increased risk of UTI. Now the clinic scare points. UTI cannot be the first sign of congenital anomalies of the kidney and urinary tract, so infants with fever of unknown origin should be screened for UTI. Urine culture should be obtained before starting antibiotic treatment with UTI is suspected, and BAC or NaPi-Pad urine should be not used for culture. Non-E. coli UTI should raise suspicion of urinary tract anomalies, and oral antibiotics are safe and effective for treating febrile UTI in children above 2 to 3 months of age. 1 of 5 infants with symptomatic UTI has a urine bacterial count less than 100,000, regardless of sampling technique. Asymptomatic bacteriuria should be not treated with antibiotics to avoid unnecessary medication. And that would be all. We have the article here and the picture.